So good morning, everyone. I'm Viet Nguyen, Technical Director for DaVinci. Welcome to our CMS Patient Access API and Burden Reduction, formerly NPRM rules session, and now the rules session. We're really pleased and grateful to have with us today Alex Muggy and Lorraine Du from CMS, who will maybe give us a little brief about our gift this morning and available to answer questions. So I'm just here really as a facilitator and can have some canned questions if you'd like to keep the conversation going, but it's really an informal session to give folks opportunity to ask questions. I know the rule just dropped this morning, so you haven't had the chance to consume it, even if you did do the Evelyn Wood speed reading course in the 80s. So I'll stop sharing and hand it over to you all, Alex and Lorraine, to kind of kick off with any opening words you have. If you have questions, I would encourage folks to use the chat in the window to kind of help kind of keep things flowing. Or if you're in Whova, I'll keep track of Whova as well. We are recording. I don't know what the turnaround time is for the access to the recordings. I think they're trying to do it as promptly as possible, but please be mindful that we are recording. So thank you. Handing it over to you, Alex and Lorraine.
Thanks, Viet. Thanks everybody for joining. We're looking forward to chatting with all of you today, answering what questions we can. If you've come with some, I'm sure that folks had some questions about policies from the first interoperability rule. You may not have had a chance to yet read in the last 3 hours what we finalized in the second rule here, but you know, we're happy to answer questions, or could even possibly give a quick but maybe slightly informal overview. I'm not sure that we were quite prepped to give you a full briefing, but we are happy to run through things if that's helpful. But I'm just going to be quiet in case folks already have questions that they wanted to bring up when they came in today. Unless, Lorraine, do you have any opening comments that you wanted to make?
No, I think if we could go through just, you know, a reiteration of what the APIs are, you know, sort of confirming, you know, similar to what's in our briefing paper, and just go through those, a summary of them, if that would be helpful to people, of what the final policies are that are in there. You know, we put final action statements in the final rule, and maybe we can just list those out. And then leave it open for questions, because I know people have been, some of the sessions that I've been listening to at the Connect-a-thon the past 2 days, I've heard some questions, and we may be able to, you know, respond to some of them to help out. And then what I have is a page up to begin to take some notes of the kinds of questions that people already have that I've heard. So that might be the most helpful thing, is maybe just list out what the API requirements are and what the burden reduction requirements are, if that would be helpful. So
I think that would be great.
You want to say what would be useful?
Along with that, maybe a subset, if you already have them identified, is for those who were able to review that, the proposed rule is what things that were in the proposed rule that you can recall that aren't in the or significantly different in the final rule. And then timelines, I think, would probably be the other topic, compliance timeline. So
I think that it probably makes sense for us to maybe do just a quick run through of everything as a whole, but highlighting kind of what was and was not finalized. I'm happy to do that, just as long as everyone understands that it's going to be a bit informal, and I do want to get through this to make sure that we have time for your questions. So so we are finalizing 3 what I'm going to call access APIs, APIs that promote better access to patient health information. The first is some changes to the patient access API. Of course, the patient access API was finalized in the first interoperability rule last May. What we are changing about the patient access API now in this final rule, in this new and final rule, is that we are requiring, in addition to the claims, encounter, clinical, and formulary information that was finalized in the first rule, we're adding prior authorization data, which would be required to be included in the patient access API. We are also requiring 3 IGs to support the build of the API, and those include the consumer-directed payer data exchange, or Karen for Blue Button IG, the DaVinci Payer Data Exchange, or PDEX IG, as well as the DaVinci Payer Data Exchange PDEX Formulary IGs. So those are now, previously highly recommended, now required for the patient access API build. So that's a significant change from Rule 1, just in terms of reducing some of that optionality and bringing these APIs into better alignment. In addition to the API itself, we are going to be requiring that payers build and maintain a process for third-party applications to attest to certain privacy policy provisions. And in this way, we are, better in some ways better engaging patients and helping them to understand privacy policies of their chosen health apps, and also strengthening the communications between payers and their patients. Then finally, we are requiring that payers report certain metrics about the patient access API adoption rates on an annual basis to CMS, and this is for our purposes to evaluate the adoption of the APIs and continue to evaluate and refine our policies in future years. So those are all important things to note. Then we've not really called it out as a separate API in the rule. It was sort of rolled up under the patient access policies, but we are also requiring for the provider directory API that payers implement the PDEX PlanNet IG. So just a heads up there that there are no additional changes to that API, except that it would now have the associated IG as a requirement, which again reduces some of that optionality and just brings the APIs into better alignment across the different payers. The second access API, I keep using air quotes and none of you can see me, but I'm putting air quotes around the word access every time I say API. So the second access API is the provider access API. This is an all new API in this rule, and it is modeled after our CMS's own data at the point of care API, which provides or enables a way for payers to send patient health information directly to providers. This one's going to sound very, very similar, if not identical, to the patient access API. This API would include claims, encounter, clinical, formulary, and prior authorization data that would again be going directly from payers to providers. Just to note, this API does not include cost information. So unlike the patient access API, there would be no cost data being sent to providers. This API requires the same implementation guides as patient access. So in this way, the technical build is nearly identical as patient access. And again, well, I won't list out the APIs every single time, but just to reiterate, that's the Karen for Blue Button, the DaVinci PDEX, and DaVinci PDEX for formulary IGs. And again, that's for the provider access. Then the third access API that we finalized is the payer-to-payer API. So in the first interoperability and patient access rule, we did finalize our policy for payers to exchange certain information when a patient requests it, but we did not require that that exchange happen through API. We do understand that many of you, particularly in this community, have explored doing that through an API, but I do note that it wasn't a requirement in the first rule, but we have now made that a requirement in this subsequent rule, in the interoperability and prior authorization rule. So, so we finalized that now when a patient requests it, or when they change health plans at the time of enrollment, that their data will be sent through a FHIR-based API using the same IGs as patient access and provider access. So Karen Blue Button, PDEX, and PDEX formulary would be required IGs for this API. We did not finalize the PCDE IG, so that's a notable change from the proposed rule. The The data that would be exchanged would be, again, the same as what is shared with providers and with patients. That's claims, encounter, clinical, formulary, and prior authorization data. Again, much like the, or exactly like the provider access API, that would not include cost information. So we're not asking payers to send their cost information from one plan to another. All of these IGs have an implementation date of January 1, 2023. So we do believe that because the patient access API is already required to be implemented starting this year, and because the other two new APIs are almost identical to that patient access API, that 2023 is a realistic target. And so we're looking forward to seeing that implementation. Next, moving to more the prior authorization focused policies. For prior authorization, we had proposed and are finalizing 2 APIs. The first is the Documentation Requirement Lookup Service, or DRLS API. And this API would use the CRD and DTR implementation guides. And we have finalized that API would initially be implemented starting January 1, 2024, and would have a phased approach such that payers are required to implement their top 10% top 10 by volume prior authorizations in the first year in 2024, and then would phase in the rest of their requirements over the next 2 years until the DRLS is fully implemented. So that one has a phased approach. The second prior authorization API is Prior Authorization Support API, which uses the Prior Authorization Support IG and works with the FHIR-based standard in combination with the X12278 to support the sending and receiving of prior auth requests and responses between a payer and a provider. We do note that for both of these APIs, providers are not required to adopt them. They are voluntary, but payers are required to build them. We fully believe and understand, that providers would need to do some build on their side, or their EHR vendors will need to do some build in order to make these APIs fully operational. And we are starting out with the if you build it, they will come approach, and requiring that payers have these in place so that then providers have something to build to. As we stated in the final rule, we fully anticipate, further down the line as part of our roadmap that we will do more to encourage providers to adopt these APIs in their EHRs as well. And we are working with ONC and looking at ways to incorporate these APIs into the certification program as well. So just important points to highlight there. So the prior authorization support API is has a required implementation date of January 1, 2024 to align with the DRLS API. Then a couple of other more guardrails. So that's the extent of the API build for the second interoperability rule. We also had some policies around prior authorization that I'll just quickly run through because these also just support, a better healthcare experience for patients. And when combined with the APIs, we think will truly streamline the prior authorization process to reduce burden for providers and also improve that patient experience. And ultimately, hopefully reduce burden for payers as well. So the first of those policies, we are also finalizing that when payers send a denial for a prior authorization, regardless of the mechanism through which they send it, if it's through the PAS API or if it's through one of the older mechanisms like fax or portals, we are requiring that payers send a denial reason with that denial, and thereby allowing providers to determine next steps. Do they need to resubmit their prior authorization, appeal it, or do they need to work with their patient on finding another course of treatment? So, so we have finalized that as proposed. Again, with an implementation date, all the prior authorization policies have an implementation date of January 1, 2024. We also finalized our policy regarding the shortened prior authorization timeframes. So payers now have a maximum of 72 hours for urgent requests and 7 calendar days for standard requests. during which time they would need to provide a response to that request to the provider. And then finally, we are requiring that payers provide certain prior authorization metrics on their website. So they're not submitting these to CMS, but they would be reporting them on their own website. Some metrics that indicate just how they're implementing their prior authorization processes. Some examples that we gave of the metrics include the percentage of prior authorizations that are approved or denied or overturned after an appeal. So payers are allowed to pick their own metrics for this one, but we also included suggested metrics and would require that payers look at comparable metrics. So their metrics may be better suited to their particular payer plan implementation. So, so that metrics proposal also with an implementation date of 2024. And then finally, I do want to highlight that the Office of the National Coordinator, ONC, has adopted the IGs that we finalized in this final rule under their regulations. So so these IGs have been adopted by HHS for use for this rule and other purposes. So I know that was a little bit of a speed through reading, but I do want to make sure that we leave plenty of time for questions. And I know that folks may have come to this session with more questions about the first interoperability rule and still haven't had time to digest this second one, but we can hopefully speak to both. So just please be clear which policy you are asking about, since we have a lot more on our agenda than we originally may have planned for today.
So
I will be quiet and let you guys go ahead and ask the questions. Go ahead, Viet.
Yes. So one question I think maybe related to kind of overall adoption was first a compliment to CMS for making it through all these comments and putting it in to the rule. And then could you, since variation and optionality in standards used impedes interoperability, can you please explain how CMS will ensure uniform adoption and consistent use of non-normative IGs codified in the CMS final rule? I think that maybe has to do with the kind of the standards update process.
Sure. So of course, for the IGs that have been finalized, those are now required for use of the floor, the base implementation for these APIs. There is also what we had finalized in the first interoperability rule, and what still applies here is the standards versioning advancement process. This is a policy that ONC had finalized, and CMS has some slight variation in the way that folks can use this process. But essentially what it says is that as new versions of the standards become available, you may adopt the new versions of the IGs. For example, you know, if we go to an SCU2 or an 1.1, you may adopt the updated version of that and use it for the implementation of your API, as long as you are still meeting the requirements that we finalized for the rule, and you're not breaking any of that connectivity, or sort of, in a sense, we try not to always use the word backwards compatibility, but essentially it is that if you are moving forward to a new version of the IGs, that you are still backwards compatible and supporting the original finalized policies for these APIs.
I put a link to the ONC description of the standards version advancement process. Another question, there was bulk data was referenced quite a bit in the proposed rule. How did it turn out for the final rule?
Thank you. I should have mentioned that. And this is the challenge of having an informal briefing and not having appropriate talking points here. So we did not finalize the use of the bulk specification, though we do strongly encourage its use. I guess just in short, you know, in looking at the comments and reviewing what folks had to say, we felt that some additional testing and time to work with the bulk specification for these particular policies may be needed. So we support everyone using the bulk specification and continuing to test it. At this point, though, we did not require it.
Great, thank you. One question here is, for data elements in the US CDI, for data elements in the U.S. core data for interoperability, were any IGs adopted? I'm not sure exactly the direction, but I think maybe I'll rephrase it, that there are a number of profiles in, say, Da Vinci IGs that may not be in US Core, US CDI, are they required based on the fact that you identified the IGs? I guess I would say.
Sorry, so can you read the original question again,
yeah,
or
well, the
you reframing again? Sorry.
Hang on, let me. I'm going to unmute you. Is it Brian? And you can ask the question, or I'm going to. Oh. Okay, there you go. Brian, if you want to unmute yourself and rephrase your question, please. Were you able? Oh, were you able to? Uh-oh. Okay, I think it had to do with the concept, and it's still somewhat confusing to folks in the community. We have US CDI, we have a US Core, and then we have profiles that are in implementation guides that were identified. Are the requirements, this is maybe not the right way to ask it, but are the requirements then the superset? So if there are profiles that are in our IGs but may not be in US Core, do they become the required profile? I hope I've phrased that.
Yeah,
You have, and I think I need to go back and look at that and think about that for a second, because to be honest, I know that this has come up and I can't quite remember where we are. The requirements do specify, though, the US CDI. So the requirement would be, at least the US CDI.
Okay. We'll hang on to that to help try to answer that after the breakout. Another question is, can you provide CMS exception process details to exchange prior authorization through FHIR and not using the X12278?
Lorraine, do you want to take that one?
Yeah, I can. So I think a lot of people know, but just to start at the beginning. So under the Health Insurance Portability and Accountability Act, there is an exception process if people want to test the use of a new standard as an alternative. There has been some information, and I don't know if it's on the website, but we can send out that information again about how to apply for that. And then there's a study that can be conducted. And so if organizations have partners and they want to do that, then they are welcome. And I think there's been some encouragement to apply for that. And then standards organizations also, if they believe that they have a standard that is more efficient or more effective or more appropriate for use, they can also either submit to HHS or to NCVHS a standard that may be more appropriate. So either the exception process or a recommendation to the secretary to use a standard. But the exception process has been documented. And as I said, if it's not on the National Standards Group's website, I will find out where that is, because I think they've done a presentation in the past of how to apply for that exception. And what you would just need to do is do a study that would indicate how that standard might be more cost effective and meet the, it's 10 elements, if you will, of how it might be more appropriate. So would it be helpful if I got that and sent it out via, and then that could be distributed?
Oh, that would be great.
Okay, I'll make a note.
All righty. There was another question here on payer to payer. Since no APIs are required between 2022 and 2023, are we going ahead with ad hoc exchanges in the interim?
So if by ad hoc, I think you're saying just any mechanism of exchange between 2022 and 2023. And that is still what the final policy was from Rule 1 is still in place. So whatever folks were planning to do, they certainly can continue to do that. We would hope that, with the understanding that the API is required in 2023, that folks will start working towards and using that API as soon as possible. I understand, and the questioner didn't specifically state this, but understand that, some folks do have concerns about, well, what do I do if I receive data in 2022 that's not for use in, like, what if I receive a PDF? Do I need to continue to send that data forward? And we did specifically address that in the rule because we understand that that is a concern. And what we have stated is that only the data that comes through in the FHIR format needs to be continued to be sent from payer to payer in subsequent years. So if you receive the data in FHIR, you need to continue to send it. If you receive data through other means, you are not required to put that into the FHIR format or to continue sending that forward starting in 2023.
Great, thank you. Question about your comment around ONC, and actually I had the similar question. Alex, could you please clarify your statement about working with ONC on the IGs codified in the new rule? Are you implying that ONC would add these CMS APIs to their existing health IT testing and certification program? That's exactly the question I wanted to ask too.
Okay, yeah, that's a great clarification. So let me talk through that one real briefly. So completely separate and apart from the actual certification program, just talking about standards, ONC has the authority to adopt certain standards on behalf of HHS. So likewise, in the first interoperability rule, ONC is actually the entity that adopted HL7 FHIR standard for the APIs, and CMS points to that, but we ourselves did not adopt the standards for the APIs. Similarly, in this rule, we are pointing to and requiring the implementation guides, but we are not using our authority to actually adopt the standards. ONC is the entity that adopts standards on behalf of the Department of Health and Human Services for these purposes. And so ONC has adopted them. That does not mean that it will have any impact on the certification program. It just means that they're putting into their regulation text under their authority, and that they can be used more broadly than just for these use cases that we are describing in these IGs, or I'm sorry, in this rule. These implementation guides can be used more broadly. For example, another agency may finalize a policy. They would also be able to point to the same standards adopted by ONC because, again, they're adopting them on behalf of the entire HHS. So that's how the standard sort of adoption is happening for this rule. Separately and completely independently, for future potential rulemaking, we are talking to ONC about ways to actually require some of this for their EHR certification program. And as I mentioned, this rule is really the first step in our roadmap to prior authorization. So, we are having payers in this rule build the APIs to host the prior authorization information. Providers were not required to do so in this rule. However, in future, and based on some of the comments that we received through the rulemaking and the conversations we are having with ONC, we will consider and we'll be working with them to consider adopting this for the certification program. But that is not happening in this rule at this time.
Okay, great, thank you. You listed a number of differences between the proposed rule and the final rule, PCDE, bulk data. Are there any, recognizing you haven't prepared a deck, are there any other ones that we should try to be aware of?
So there are some additional tweaks and adjustments to policies. So
I think there's a couple, like there's the I think one that's important for folks is the documentation requirements lookup, where we originally, it implied that one would have to do all of the requirements, and we're suggesting a phased approach where it was the top 10 prior authorization requirements, initially, and then moving it over a period of time to do the rest, so that it gives organizations really time to evaluate which the most important ones are, and to build it out, to do it in a more systematic way. So I think that's an important one. The other one of the other ones,
I was going to say, I think some of the challenge in this is determining which policies or which adjustments are most critical to highlight on the call today. Lauren, you were about to say another one, though. I'll let you finish up, and then I know one other one that I wanted to highlight.
Yeah, no, go ahead.
Okay, sure. So I wanted to highlight that we, in the proposed rule, we did propose a certain extensions, exemptions,
Right.
exceptions process, all of the X's. You know, we had different circumstances under which Medicaid fee-for-service payers could request an extension or exemption from the 4 of the API policies. So for the provider access, payer-to-payer, DRLS, and prior authorization support APIs, they would be able to request these extensions, exemptions. We also had proposed a policy for the QHPs to get exceptions to the policies, you know, under certain circumstances that would essentially require them to request an or apply for an extension during the certification process for the QHPs. The feedback that we received was that these exceptions, extensions, and so forth were not equally applied across the payers and could be confusing, and also that there was not a process for Medicaid managed care to apply for or get one of these exceptions and extensions. We did not finalize those policies. So right now the implementation dates are what they are in the rule. There is no process for exceptions, extensions, and exemptions, all the X's again. There is no process for those X's for any of the payers as finalized in this rule. However, we did state in the rule that we will consider, as we get closer to implementation, enforcing some sort of enforcement discretion and potentially extending timelines. We'd like to see where we are as we get a little bit closer to implementation, but it's important to note that if we were to issue that enforcement discretion, it would apply equally across the different payer types impacted by the rule. So it wouldn't be a separate application process for one versus another or anything like that, but it'd be more uniformly applied. So that's one that I wanted to highlight. And then there are some other minor adjustments, not so much on the technical side that folks may be concerned with, but for example, we required certain metrics about the patient access API being reported to CMS. We had proposed that to be on a quarterly basis. We're finalizing that as an annual process. And also the metrics around prior authorization itself. As I mentioned, you know, we had proposed a certain set of 7 metrics that would be required to be reported by all payers. And we actually removed the requirement for that to be the specific metrics. So payers still need to report metrics, but they can actually determine what their own metrics would be. They can use our list or go with their own set that kind of better reflects their own practices. So I think those are some of the
Right.
major changes. Did I miss anything, Lorraine?
No, that's what I was going to point out. I thought those were
Okay.
significant. Mm-hmm.
Thank you. Typically, when we start these conversations in a formal session, you will typically list what entities are under the rule. I know we and probably a number of others noted and understood why Medicare Advantage programs weren't, but were there any changes to who was covered under the rule, and anything you could share about Medicare Advantage program?
Sure. So we did finalize as proposed that this would apply to Medicaid fee-for-service, CHIP fee-for-service, and Medicaid and CHIP managed care, as well as qualified health plans and the federally facilitated exchanges. This does exclude Medicare Advantage. They were not part of the proposed rule, and thus we, of course, did not finalize the policies for them. But as we mentioned in the final rule, and we also said in the proposed rule, you know, we will consider Medicare Advantage for future rulemaking. And we did receive, that was one of the top comments that we received is that folks would like to see this extended to Medicare Advantage. So that is something that we will certainly be looking at for the future.
Alrighty. One question, we're all pretty familiar with the major EHRs, but the question was around specialty practice management systems like ambulance software, home health. These are not necessarily FHIR enabled or ONC controlled. However, prior auth is mandated for these programs. Is there a plan to work with these software vendors and provider organizations? I think you mentioned before that the provider side wasn't required, but the payer side was for the prior auth.
Right. So And again, we've been describing this sort of as our roadmap to electronic prior authorization, but at this time, we are not requiring these policies of providers, so it wouldn't apply to those health IT developers that are regulated by ONC or others, or the providers that they serve. However, going forward, we will work with ONC. We will also work with the software developers, and we would be very interested to hear from folks, how we can best support getting these policies into the software used by all of the provider entities. So for anyone using prior authorization, we feel like these are critically important policies for streamlining those processes and reducing the burden on providers and reducing burden on payers. So we would hope and strongly encourage EHR vendors, other software developers to look at these policies and determine how they can support their clients in adopting these APIs. And as part of our longer roadmap, that is something that we will explore in ways that we can help facilitate that and encourage or require it.
Thank you. This is a question from Rob McClure, and actually something that came up in some conversations I've had as well. Let me read the question and then add a little bit of a frame. The question is, or the statement initially is, you stated with regards to CMS SVAP that new versions of specified IGs can be adopted, but there is a, quote, requirement to maintain backwards compatibility with prior version, which I know you're hesitant to use the word backwards compatibility. So the rest of the question is, yet non-normative STU IGs, as most of these are, in fact, allowed to make breaking changes when necessary in a version change. Does CMS intend to require this higher standard for IG version changes? If true, this is not how we interpret the ONC SVAP process works. So I think it's the combination of what we've been calling, or I call the kind of impedance mismatch between meeting a requirement that's in a rule, and that rule identifies an IG, but the standards process recognizes that STU IGs may have breaking changes until they go normative. Can you clarify maybe your understanding of ONCs or any discussions about how we kind of reduce that mismatch between what's required and what's in the IGs?
And Lorraine or any of our supporting MITRE team, if you'd like to jump in on this as well. I think I'll just say there are some minor differences in the way that the ONC and CMS implement the SVAP process, just in terms of, I believe ONC requires some level of approval of a new version, whereas we do not, but we do want to ensure that sort of backwards compatibility. And that is to ensure that if a patient is trying to maintain access to their health records, we don't want to see that connection lost. We don't want patients losing access to their health records, their health information. That is really the intent of these policies. And so we would not want to see that chain broken. However, we do understand that there are going to be changes and adjustments. We already know that folks are working on newer versions of the IGs. We would like to see that maintain the backwards compatibility. We also understand that if there are significant changes to the versioning, we may need to do additional rulemaking to update that floor, as it were. And that's one of the challenges that we are very keenly aware of in this type of rulemaking where we're specifying standards. One of the challenges of being required to identify a specific standard is that when it is updated, that can sort of immediately put your regulation out of date. And that's why we have the SVAP process in place to account for some of those adjustments. However, if they are major breaking changes, that is something that we would want to explore and consider for future rulemaking.
Okay, great. Another question, recognizing that MA organizations are not included, is a correct statement to say that the ad hoc electronic exchanges non-FHIR for payer to payer be maintained even after 2023? I think there's a lot to unpack in that question.
Yeah, I think, and maybe if you could read it one more, or I can probably look at it in the chat. It might help me to actually see it, but
let's say it out loud.
The concern about,
is it a correct statement that ad hoc electronic exchanges, non-FHIR for payer to payer, need to be maintained even after 2023 And I think that applies to the MA since they're not in the rule.
Mhm.
Right. So are they
Yes,
saying that
so
because they're
MA would,
excluded, is that it?
As of today, let's say.
yeah, so MA would still be required to maintain the payer-to-payer data exchange. They are not required to do so via FHIR. So if the MA plan is conducting a payer-to-payer data exchange in 2022 or in 2023, anything going forward, essentially because there is no other rule for them, they would continue the process as outlined in the first interoperability and patient access rule. That said, if an MA plan is sending data to a Medicaid payer, and then Medicaid payer is now subject to the requirements of the 2020 or the 2023 requirements of this rule, the Medicaid payer would not need to send that data forward if it was not in a FHIR format. So if it is sent via FHIR, then they would need to continue to send via FHIR. But if it's not, then we would not be requiring them to translate that or continue to send that data forward. But there's a lot to unpack there, and I think that this highlights one of the points of misalignment that is now in existence because of the change in policies, and that's certainly something that we'll consider as we look at Medicare Advantage for future rulemaking.
Great. One other question: what does the rule say about EHR vendors supporting DTR Smart on Fire apps?
So this rule doesn't regulate EHR vendors, so we did not specifically go into any details about how or whether they would need to support that. I think the only real discussion there is that we are going to continue working with ONC to determine if there are requirements for health IT developers and EHR vendors to support this in the future. Okay.
This wasn't a question, but I think is a task maybe for us, Rob, in the HL7 community. To work with CMS and ONC, maybe in the US realm work group, to address the impedance mismatch between the SVAP and the IG publishing, the maturation process, and provide a better explanation to the community. There's one more question, a couple more questions actually. Oh, no, he just agreed. So I believe I've gone through all the questions in the chat. Let's give folks another 30 seconds to put any additional questions or highlight ones I may have missed. There was only one in the HUVA that I think was addressed around patient access API rules and the overlap with the burden reduction rule. So I think we covered that, and of course there's probably many more details to clarify.
Hey, Viet.
Yes.
This is Lorraine. I just wanted to add one thing about SVAP and what you and Rob were talking about. And I think everyone knows, one of the reasons that SVAP is so great is because people have been complaining about the regulatory process taking so long. And so it is an opportunity to enable people to use newer versions of the implementation guides. But we really do appreciate as you said, sort of the misalignment about when an implementation guide goes, through the STUs and then becomes normative, that's the challenge we have to work through. So we really do want to participate in that discussion about how we make sure that we enable people to use the new versions, but not go astray of what HL7's process is. But I think the effort was to really be able to let people use the newer versions without having to wait for us to do regulations, but to make sure that it sort of works for everybody with your process and also through regulations to not hamper innovation.
Yes, and I think at least I'll speak for myself that's a good thing for us to be able to innovate and to improve without being too hampered. And of course, Rob and I, as terminologists, really think it's so important that we make sure we're using the right terms, and terms like ceilings and floors and things like that. We want to make sure that we're clear on what that means. So I don't see any new questions. Oh, new question. Any comments on the need for fast infrastructure for the many-to-many APIs? That's a good question. Do you address fast at all in the rule or reference it?
We compliment it. We got a couple of comments on it saying, what about
Yeah.
fast?
Okay. So that's
I don't believe we had much more of a discussion, but I'm curious, Dave Hill, if you're on, if you had any additional points to make there.
yes. Let me unmute you, Dave. Oh, were you able to unmute yourself?
Yeah, I
Oh,
was.
okay, great.
Yeah, I mean, I think there's lots of good things that are going on with the fast infrastructure, and I think it's definitely area that we need to continue to work on and try to integrate into what our health IT strategy. So I think it's all good.
Okay. Question from Melanie. Can CMS say anything about the provider directories or payer directories? Maybe, or just reiterate the plan net? Or...
Yeah, aside from stating that we did finalize the plan at IG for the provider directories, that we had finalized the API in the first rule. I think, if Melanie, if you're asking about future plans for directories, I don't have any further statements at this time, and there were no other proposals for this rule. This is something that we continue to look at as an area of interest and are very focused on, and working with our colleagues at ONC and in industry to try to figure out some solutions to some of the challenges that we know exist due to some of the lack in consistent provider and payer directories. Okay,
well, great. Well, on behalf of Da Vinci, the HL7 community, and the broader community, I want to thank you, Alex and Lorraine, for being here with us this morning. This was I'm glad we planned this in advance. I'm sorry you didn't have much time between the dropping it and this call, but we really appreciate all your efforts to try to help inform us and help us better understand the final rule. Da Vinci, of course, we want to provide additional forums as questions arise, like they did around the patient access API. So we will work with you to see if we can get you on our schedule for our community forums and additional education events. So we will then now pick up the rule and try to digest it over the weekend. I'm sure, at least for the Da Vinci folks, like we did with the Patient Access API, we'll be gathering our community's questions and submitting it to you for clarification, response, etc. So we want to thank you again, and we'll sign off here. Have a great rest of your day and a great rest of your Connect-a-thon.
Thank you all.
Thank you.